Hello, welcome to another episode of the lecture on management of medically compromised individuals. Myself, Dr. Epan Thomas. I am the professor and PG guide in Department of Oral and Maxillofacial Surgery, Pushpagiri College of Dental Sciences, Kerala. And in today's lecture, we'll talk about patients dealing or patients on long-term steroid therapy. We do get many patients in our dental department who's to undergo dental treatment who are on long-term steroid therapy for various reasons or various conditions. Nowadays, steroids are being used so extensively by anyone and everyone that these things might not be noticed and these things might be overlooked. So it's very important to take a proper history and elicit any significant therapy of steroid that patient is taking for any reasons, for any sort of systemic disorders or disorders which can actually give us a lot of complaints and trouble later if it's not noted and the necessary measures are not taken. So with that brief overview, let me just move on to systemic steroid therapy or steroid therapy and dental treatment management. We'll have a brief overview about the adrenal glands, the various hormones of adrenal glands, and what are each hormones, the main functions of the most important of those, that is the cortisol hormone, and how it affects the various systems of the body. Why is it so important to have a detailed notice on this cortisol and its various functions, and what are the dental considerations that one should think about a patient on long-term therapy. How will we deal in case a patient develop adrenal crisis, and how to take measurements, or what are the precaution measurements that one should take to prevent such problems. Well, just remember, just think about these two small glands, the ones in the pink, the magenta color ones. They are the two adrenal glands. Adrenal glands are actually nothing but a pair of two glands situated on top of the kidney on either side. So they are a paired glands, and they're situated on the kidney or the suprarenal surface on either side. And now, if you think about these adrenal glands, they have basically two structures. This is a cross section of the adrenal gland. It's comprising of two main structures. From one, the outer one, what we call it as the adrenal cortex, what we see here in the outer three layers here, and the second one is adrenal medulla. These are the two core. The inner core is called as the adrenal medulla, and the outer core is called as the adrenal cortex. Okay, now this adrenal cortex and adrenal medulla are actually comprising of different layers or different zones. The outer cortex is comprising of three different zones. The first one being called as zona glomerulosa. What you see as a brown layer all around this cross section is the zona glomerulosa. The second one is the zona fasciculata, the cream color, the off-white color. What you see, a thicker layer after the zona glomerulosa is the zona fasciculata, and the last layer is called the zona reticularis, that is the innermost layer immediately next to the medulla. The innermost thing is the medulla. So the three layers from outside to inside are zona glomerulosa, zona fasciculata, and zona reticularis. Now the important hormones of the adrenal gland are produced from various layers of these adrenal glands. Now that you have an idea about three layers, let's see what each layer actually forms. The first layer, the outer layer, or the zona glomerulosa, actually secretes the mineralocorticoid hormones, that is aldosterone and corticosterones. So these are mineralocorticoids and secreted from the zona glomerulosa, the outermost layer. The second layer, the thicker layer, what we call it as zona fasciculata, actually secretes the glucocorticoids, that is the cortisol and cortisone. These are the two important hormones, the main hormone, which is actually secreted by the middle layer of the zona fasciculata. Okay, and the innermost layer, what we call the zona fasciculata, actually secretes the sex hormones or the androgens, that is the estrogens and testosterones. These are the three layers and the different hormones secreted by the adrenal cortex. Let us have a look at the adrenal medulla too. The innermost core medulla is actually responsible for two types, mainly the catecholamines, the epinephrine and norepinephrine, and also a few peptides which are comprising of the somatostatins and substance P. Now this is in brief about the adrenal gland which is situated or located on top of the kidney or the suprarenal surface, which has two major components, the adrenal cortex and adrenal medulla. And the adrenal cortex is responsible for secretion of the hormones called as the glucocorticoids, mineralocorticoids, and sex hormones, where the adrenal medulla is responsible for the hormone secretion, which is actually called as catecholamines and peptides. Now we'll discuss these things one by one. Now, all these hormones, the adrenal glands and the adrenal hormones, actually have a very wide, extensive role, and it affects the nervous system, the immune system in various manners. Okay, it affects the nervous system, immune system. Nervous system, it is actually responsible for a lot of conductions. Then, immune system, it affects the cells, the lymphoid cells, the cardiovascular cells. It has got a play. It plays a role in the cardiac output and the blood pressure, respiratory systems, the sex hormones, the muscular system based on the electrolytes, then other integumentary systems. Also, it's got a extensive, all over the body actions. This particular the group of drugs, what we call it as steroids in general, and the hormones which is secreted by the adrenal cortex and the adrenal medulla. Let's see about the adrenal cortex hormones one by one. The first one is the aldosterone. Okay, it has got a very important role in regulation and control of salt balance in the body. Salt and water retention is actually a very important part of the homeostasis. So these hormones play a very important role in maintaining the salt balance in the blood. That is the principal hormone responsible for that is the aldosterone. Okay, that is secreted by the, like what we have seen, the outermost layer, that is a zona glomerulosa. Okay, and the next is you have a second layer actually, or the third layer, the regulation and control of sugar balance. This is again the most important hormone in what we call it as this thing, part of these steroids, and that is called the cortisol hormone, and that actually plays a very important role in control of sugar balance. So that is something what we have to think about. It's from the zona fasciculata. So this particular hormone comes from zona fasciculata and actually plays a vital role. Now let's see what is the third hormone. That is actually coming from the zona reticularis, that actually comprises of the sex hormones or the androgens and estrogens. So these are the principal hormones which is actually synthesized and secreted by the adrenal cortex, and they do have their important role in controlling salt and water retention, that is aldosterone, secreted by the zona glomerulosa. Then very important role in the control of sugar and sugar balance, that is zona fasciculata, through its hormone called cortisol. And of course, definitely plays a vital role in the sex steroid hormone, that is the androgens and estrogens. Now that you know these hormones and the adrenal cortex, let us talk about the adrenal medulla. The adrenal medulla actually, principally, they actually secretes the hormones called as catecholamines, and these are involved in fight or flight response, actually connected with the sympathetic activities of the body. And the principal hormones are epinephrine and norepinephrine. That's something about this adrenal medulla. Now that we have an idea about the hormones of the adrenal cortex, how are they formed, how are they secreted, and also that in medulla, what are the hormones and where does it deal? Let us move on to the next part about the functions of these steroids. Now, the steroids, cortisol, is predominantly called as a stress hormone. It is involved in the various form of stress in response with whether it's physical stress or emotional stress. Stress doesn't mean it's always or anything connected with the fear or anxiety. Anything which concerns with emotion, anything which concerns with an increased demand of the body. It could be, when you're sick, it could be a fever, it could be any injury, it could be trauma, whatever it is, whether that's emotional or physical demand of a body. Whenever there's an increased metabolic response, demand, your body is at stress. So the cortisol is very important to maintain this particular, balance and to make you capable of meeting the stress. So it's a very important hormone. So that is something what you have to keep in mind. It actually takes part in many of the homeostatic maintenance actions. Homeostatic means something which regulatory actions and maintenance actions in various types of systemic actions. So predominantly blood pressure. Okay, now by virtue of its action on the heart, by virtue of its actions on the sympathetic system, by virtue of its action on the aldosterone or the salt and the water retention, it plays a very important role in controlling the blood pressure. immune system. Okay, so the principal agents of the immune system are your WBCs, or the leukocytes, and the T lymphocytes, and this steroids has got a predominant role, and in mild doses it's actually immunostimulatory, but on a proper therapeutic dosage it actually compromises, it actually suppresses the immunity, and in general or in grossly these are called as immunosuppressant drugs too. It actually make your system more susceptible. It actually inhibits this system under the thymus, and the cells produced by the thymus and the lymphocytes, the T lymphocytes and WBCs, the complement systems, all these are under the influence of steroids. They are a little bit kept down, they are inhibited, thereby reducing your immunity or immune system, and that is the reason they are called as immunocompromised drugs or immunocompromising drugs. Protein metabolism, well, in doses, therapeutic doses, it actually breaks down in excess doses of this thing. The proteins are broken down for the purpose of generating energy and the purpose of formation of glucose or gluconeogenesis. And this actually catabolism of the proteins is actually giving rise to wastage of the muscles and other features. So you should be thinking about this particular part about the steroids giving rise to protein metabolism, an important role in that. Carbohydrate metabolism, well, the control of blood sugar is very important necessity factor, because that actually gives us a lot of energy. The glucose is a main source of energy, and this metabolism of glucose is very important, and this carbohydrate metabolism is taken care by the steroids to a much extent. They actually always increase the blood sugar level by various mechanisms, the principal one being gluconeogenesis. They help to generate glucose from known carbohydrate sources, like I told you earlier, from protein, from the fat, and things like that. They also decrease the peripheral utilization of glucose, and they also increase the glycogenolysis. These are the mechanisms by which the steroids are principal, hyperglycemic agents for increasing the blood glucose level. Fat metabolism, again for the purpose of generating energy to meet the stress, the steroids acts on the fats and breakdowns, and they create a lot of energy and calories, and even sugar in extremes actually is taken out generated from these fat through fat metabolism also. Another one very important action of the steroids is anti-inflammatory action. This got a very massive anti-inflammatory action when compared to NSAIDs. It acts at the higher level, it acts at the phosphodiesterase level, and it actually has got an action on the WBCs. It actually reduces the function of the WBCs. The phagocytic activities actually cut down. The chemotactic factors cut down. The prostaglandins are active mediators of inflammation are inhibited. The mast cells, they actually stabilize the mast cells so that degranulation and the release of these inflammatory mediators doesn't happen, and various other ways in all of the different mechanisms. The steroids has got a very potent anti-inflammatory action. Now, these are a few of the gross and the major actions and the functions of the steroid that one should be having a knowledge about. With that knowledge, let us move on to the next part. How is the regulation happening in terms of these cortisol? Now, always remember, there is always a balance. As you can see, there's a balance of the requirement of the cortisol. Your blood levels are maintained with the adequate homeostatic mechanism, depending upon the demand and depending upon the supply. So all these are at a normal level. An average daily secretion of cortisol is about 25 to 30 milligrams. The secretion of the cortisol or these particular steroids is maximum seen in the early hours, in the morning hours, when you sleep and get up, and when your system is going to start functioning with all all the properties. Then you need to have this lot of steroid, which actually gives you a lot of energy. So in the early days, actually about 20 in the early morning times, about 200 to 300 milligrams is seen as a spike release of these steroids to meet the early demands when your body wake up from sleep. There onwards, the secretion slowly comes down. So an average of 25 to 30 milligrams of steroids is actually required per day. Now let us see this how these are being regulated. So whenever there is secretion is less, whenever the levels of your steroid in the blood is less, there is always a sudden stimulatory impulse or a stimulatory positive feedback mechanism which is sent to the hypothalamus. Okay, the hypothalamus receives a positive stimulus, so whenever there is a reduced level of steroids, so this hypothalamus in turn secretes the pituitary gland. The anterior pituitary gland is part of the anterior part of the pituitary gland is what are called stimulated by the hormone which is called a CRH or corticotropin releasing hormone. The CRH is released from the hypothalamus to the pituitary, which stimulates the anterior pituitary, and anterior pituitary in turn stimulates the adrenal glands through a hormone which is called as ACTH or the adrenocorticotropic hormone. So in response to stimulation from the hypothalamus, the pituitary gland releases the adrenocorticotropic hormone, which actually stimulates the adrenal gland to release the steroids into the blood, and the levels are met with. So this is in brief how whenever there is a demand of the steroid, whenever there is a stress in the system, the increased demand of the steroid is met with. Now let us see what happens the other way around. Whenever there is an excess of steroid, what happens? Now see, here you can see there is an excess level of steroid. Again, it has to be having a balance. How does the control happen? So immediately whenever there is an excess level of steroid, like for a patient who's taking exogenous steroid, a patient who's taking steroid tablets, steroid preparations for something or the other. So all these patients who are medicated with the steroid therapy will always have an excess level of steroid in the blood. So whenever there is an excess steroid level in the blood, a negative feedback goes to the hypothalamus. Okay, whenever there is a level excess in the blood, the negative feedback goes to hypothalamus. The hypothalamus then later actually do not send any stimulatory impulse to the pituitary gland. Pituitary gland actually do not send any stimulatory effects to your adrenal glands, and there is no release of further corticosteroids or steroids into the blood system. So that's why it's controlled. Now this is what is happening whenever there is an excess level of steroid. Now let's see a patient who's on a long-term steroid therapy. Any patient who's on long-term steroid therapy actually will have higher levels of blood steroid always. There's a blood cortisol level or the blood hydrocortisone level will be always higher on the higher side. So the problem is this system is always active. I've told you the negative feedback system is always active. So what happens when the negative feedback? No hypothalamus stimulation, no pituitary stimulation, no adrenal gland stimulation. So when this lack of stimulation continues for a long period of time, what happens? The adrenal gland undergoes atrophy, lack of function and atrophy. It's called disuse atrophy. So whenever levels of, remember this is how it happens simply. Now whenever the blood levels of steroids are always on the rise or at a higher level because of this exogenous steroid therapy taken for various reasons, this impulse to the hypothalamus is always negative feedback. Hypothalamus impulse to the pituitary is again negative. Adrenal cortex is negative. No stimulation happens. So when this continued phase of non-usage of the adrenal glands happens, it undergoes disuse atrophy. So the problem with that is whenever there is a severe stress situation which requires more than the actual levels in the blood, otherwise body always compensates. But in this particular case, that compensatory secretion of the adrenal cortex doesn't happen, and patient will end up in adrenal crisis, a real fatal emergency situation. Okay, that is how these things. That's the reason why you should understand that all these medically complex conditions does have its own significance, and there's a pathophysiology underneath it. So one should be actually very thorough knowledge about all these pathophysiology, so you can identify, you can manage, you can also prevent all these medically complex conditions, and definitely and certainly you can prevent complications. I've told you earlier in the previous classes also, 80 to 90% of the complications that arise in dental practice are because of lack of managing properly patients with medically compromised conditions. So that's why I said and significance of this pathophysiology. Okay, now that you know what is disuse atrophy, what happens to the patient who is on long-term therapy, why is that patient unable to cope up with stress when there is a additional stress. For example, the procedure what we are doing, a surgical procedure, patient is under stress more than the normal. So in such situation, what happens? The adrenal gland won't release steroid because it's already undergone disuse atrophy, and patient end up in a fatal complications like adrenal crisis. Now I've told you what disuse atrophy. Okay, all these things has to be kept in mind. Now, what are the problems that we face in patients with long-term steroids? That's something what we should understand. I've told you earlier, any systemic condition when we take it up for considering the dental management, we should always take in heads in the different types. Like one is the problem associated, and what are the risk factors, and how will you manage the cases, and what are the measures of preventing those. Okay, so let's see what are the problems associated. They have a compromised immune system. I've told you earlier, because of the inhibition of the WBCs and the primary line of defense, the leukocytes, the polymorphonuclear cells, the complement, the mediator systems, all these the T lymphocytes are being inhibited by the steroids. They have a immune mechanism which is actually compromised. For the same reason, they are more prone for infection, and they have a delayed wound healing also because of this problem, because the macrophages, phagocytic property, and healing, and all these are simultaneously delayed in these individuals. Then there are another one problem is, I've told you earlier, patients who are on long-term steroids, they're prone for developing this adrenal crisis, a fatal complication, when some real stress invoking procedure is performed in them without taking adequate precautions. Then they also have a tendency to have hypertension because the excess levels of glucocorticoids or the steroids have shown to create an increase in the blood pressure. And then patients on long-term steroids, when you prescribe NSAIDs, have to be very careful because they inhibit the prostaglandin synthesis also, this particular steroids on long-term. So the gastric mucosa, the gastric lining actually has got a protective PGE2 lining, or the prostaglandin lining, which is actually totally washed out in patients on long-term steroids because of the lack of prostaglandin synthesis. So again, when you're giving an NSAID, which is again acting by inhibiting the prostaglandin, so the gastric prostaglandin synthesis also is inhibited, so it leads to further irritation, acidity, ulcerations, and problems like that. So you have to be careful in prescribing NSAIDs in patients with long-term steroids. Well, you're using with LA with adrenaline. Adrenaline is actually known to be a hyperglycemic agent. Again, it increases the blood glucose level by various mechanisms. And steroid, as you know, the patient who's taking steroid, long-term steroid therapy, as also having a hyperglycemic effect. That's why you see diabetes or a hyperglycemia as a side effect in patients with long-term steroid therapy, because all these patients on long-term therapy has got this effect on the carbohydrate metabolism, wherein which there's gluconeogenesis from the non-carbohydrate sources. Glucose is generated, thereby leading to increase in the blood glucose level. The peripheral utilization of the glucose is reduced, so thereby again increase in the blood glucose level. Glycogenolysis, breakdown of the stored glucose again from the liver, that is again another reason for the increased blood glucose level. So all these contribute to a hyperglycemic situation. So adrenaline, which is again a notorious hyperglycemic agent, when used in patients with long-term steroids, has to be dealt with carefully. Avoid intravascular administration, and all these procedures has to be done with care. Now let's see a little bit about what is this Addison's crisis, or adrenal crisis, or this, why is it fatal. Okay, now when the adrenal glands are not functioning because of this disuse atrophy, like I've told you earlier, the long-term high dose of steroids in the blood actually makes these adrenal glands non-functioning. When such non-functioning adrenal glands arise, what happens? You have a situation where there is hardly or any sort of steroid which is actually present to meet the stress what is created by a dental procedure or any such matter. And overall, the indirect effect, when these hormones are less in number or in quantity, the liver function is also affected because there's a decreased liver function, and again the stomach digestive enzymes decrease, leading to indigestion problems and gastric motility complaints. When the liver function decreases, what happened? The stored glucose is not released, and there's a low sugar level which is actually in the blood, hypoglycemic situations, and all these stomach digestive complaints give rise to intestinal motility, increased motility, and diarrhea, and abdominal cramps and vomiting. And all these together, when there's a severe low sugar condition, patient will undergo situation which is leading to brain coma and finally death. So this is in brief what happens in a non-functioning adrenal gland, which is because of a long-term steroid therapy. And there's a continuous low levels of the endogenous steroid, which actually affects the liver function, which is decreased. Again, the stored glucose and levels is actually cut down, so there's a resultant hypoglycemia, low level, and when it goes below a normal level, it comes to a situation where the brain undergoes coma and fatality and death. Okay, that is one way it's happening. Another way is basically when it affects the mineralocorticoids. Okay, and when there's overall steroid or the cortisol or the adrenal cortex suppression, what happened? The aldosterone is also similarly very low or absent in situations. So what happens? We have learned that this is responsible for salt and water retention. So what in this, when the hormone of aldosterone is less, what happened? The salt and water gets excreted through the kidney, which was otherwise always being absorbed by this hormone. So when these get excreted through the kidney, that's the heart irregularities and the cardiac output decrease. The blood pressure falls, the cardiac output decrease. The electrolytes very important, that the sodium, potassium, all this is very important electrolyte that affects the concerned bodies. The cardiac properties alter, and when there's a lot of volume loss, the low of blood volume or the low of fluid volume, and then it leads to a low cardiac output and the low blood pressure, again giving rise to a patient condition called shock, what I was talking about this, and finally brain and coma and death. Now, this is in general the pathway how Addison's crisis or adrenal crisis actually finally ends up, or how it becomes fatal in individuals. So, this is how I hope you've understood basically how an adrenal gland suppression give rise to all the different hormonal inhibitions, and when these hormones are inhibited and when there is lack of these hormones, how all these multiple organs are affected in a bad state, which is finally leading to shock and then brain coma and death. Let's move on to the next one. The signs and symptoms of adrenal crisis. Early signs patient can make a patient will complain of weakness, acute abdominal pain, nausea, vomiting, altered sensorium, poor judgment, uncooperative. These are all signs and symptoms. The weakness, the abdominal pain is again suggestive. I've told you earlier, because of the gastric juices and the intestinal motility problems and muscle cramps, and nausea, vomiting. All these are connected to the gastrointestinal complaints. And altered sensorium, poor judgment, uncooperative are all connected with the loss of severe sodium and potassium levels on the body and the electrolytes level. And hypotension, again because of the excess salt and water excretion. When the fluid volume is lost, hypotension happens. Fever, because in response of the body to compensate. Hyponatremia, I told you, when the sodium and potassium is excreted, the blood volume and the sodium levels in the body comes down, and that's the reason there's a compensatory hyperkalemia. Hypoglycemia, because I've told you the liver functions is not happening, so there is not mobilization of glucose from the liver. So I'll find that gives a situation where there is a shortage of blood glucose level and the hypoglycemia. For the liver functions, since it's altered because of these situations, then the hypercalcemia, there's again mobilization of excess calcium. That's also part of this adrenal crisis. So these are the signs and symptoms of adrenal crisis. And let's see, this is just a chart just to show you how it is actually connected with other drugs. Prednisolone, methylprednisolone, dexamethasone, betamethasone. These are the synthetic forms of corticosteroids which are used for therapy. And now such patients, once you have diagnosed based on signs and symptoms, how do you manage? Let us see what is the aims of manage. A prompt recognition based on the history part, based on signs and symptoms part. Early diagnosis is very much essential and prudent for managing the patient successfully. And administration of parental hydrocortisone substitution or replacement of replacement of a steroid. Parental hydrocortisone has been very important and crucial. Rehydration and management of electrolyte imbalance. I've told you there is a lot of fluid loss because there's no salt and water retention because of the lack of aldosterone. There's a lot of fluid which is being excreted to the kidney, leading to dehydration. So rehydration and management of the electrolyte abnormalities is again very important key. How do you manage? Let's see. Now, with those aims in mind, just remember Those are the aims what we have to think about. Now, how do we manage? Now, bolus injections of hydrocortisone. I've told you supplementation of hydrocortisone is very much essential. 100 milligrams in IV bolus dose can be injected. And if IV line, sometimes because of the severe hypertension, you might not get the IV line. So in such situation, you can even go for a intramuscular hydrocortisone. And it has to be followed. Initially, it has been later followed by 200 milligrams of hydrocortisone per day, per every 24 hours. Either you can actually have in the form of infusion, a continuous infusion, or if you want to split it, you can actually give it as 50 milligrams of hydrocortisone per IV or IM every 6th hourly, 4 times a day. So this is how the early first part, the bolus injection of hydrocortisone. Then if your IV line is difficult, you can go for IM hydrocortisone. Then you have to follow 200 milligrams of hydrocortisone every 24 hours or BD dosage, or you can even give 50 milligrams hydrocortisone every 6th hourly or 4 times a day. Then rehydration, I've told you, because of severe water loss associated with this excretion of the fluid, you have to go for rehydration. Has to be done at with isotonic saline is the ideal one because it contains sodium and electrolytes also. And a rapid infusion of 1 liter of isotonic saline within the first hour is very crucial to get the rehydration back. Or you can also give 5% glucose in isotonic saline, because I've told you there's a severe hypoglycemia also. There's a hypoglycemia, severe hypoglycemia. There is loss of this salt, and and another one, lot of volume of water is also lost. So rehydration should be aimed in all these things, and follow it by continuous IV isotonic saline. Then you can continue that later depending upon the patient's situations. And after each and every step, you have to monitor the patient closely, monitor the vital signs, the BP, pulse, temperature, respiration, all those has to be regularly monitored. And the serum electrolytes, we should know whether after supplementation of these IV fluids, whether the serum electrolyte levels are picking up, then whether the hypoglycemia status is picking up. So based on that, you have to either continue the parenteral glucose therapy. Then venous thromboembolism is actually recommended in some individuals due to some reason, not very sure about the exact mechanism is not mentioned. And the short course of this proton pump inhibitors or the antacids is actually recommended to prevent this gastric stress ulceration, because the stress induced by such situations will actually prevent, or which create a lot of trouble for the gastric mucosa. So a proton pump inhibitor would be ideal. And if the patient is clinically stable, if the patient is responding well to the medications what you have actually prescribed, then you can taper the hydrocortisone, and the replacement doses can be initiated usually within about 2 to 3 days. So after all these rehydration and replacement with hydrocortisone, if the patient gradually vital signs are within normal limits and the patient is becoming stable, we can think about tapering this hydrocortisone in 2 to 3 days time. You might have heard about this rule of twos, like how do you make out if the patient is actually steroid dependent or not, whether the patient's adrenal gland are atrophied or not. So there is something called a rule of twos. You might have heard it earlier. Now just remember, if the patient, any patient who has been taken more than 20 milligrams of cortisol or any drug therapy which is equivalent to more than 20 milligrams of cortisol, if a patient is taking per day, for a more than 2 weeks duration continuously in the last 2 years, anytime. I repeat, any person who has taken more than 20 milligrams of cortisol or equivalent drugs per day for more than 2 weeks continuously duration, anywhere during the last 2 years, such patients should be considered as steroid dependent and has to be dealt with carefully whenever you are doing any procedure which is evoking a lot of stress. So that is about the rule of twos. Okay, I hope it's clear. Now prevention is very important. Now that you see, the main thing I've told you, all these complications arise because you have either overlooked or you have not done the necessary homework. Now, if you know the patient's details from the history and you have realized these particular steroid therapy and patient is on long-term therapy, then the best thing is to take adequate precautionary methods or preventive methods. How we do that? If the patient's medication, the external medication is something equivalent to 25 to 30 milligrams of cortisol per day, that means that's something connected to the normal routine dose only. So if the patient's drug is in that range, you need not actually give additional steroids. Okay, you don't have to give additional steroids. The same drug has to be continued, that's all. If simple extraction is required, then continue the same steroid dosage if this type of drug is being taken. Okay, if you're doing a more stressful procedure like a surgical extraction, a long-term time-consuming flap surgery, okay, a difficult canine impaction, or anything of that sort under local anesthesia which induce or which evokes a lot of stress for the patient, then such patients the dose has to be doubled on the morning. Okay, that is something very important. And another one thing is prior surgery in that hydrocortisone should be kept handy with you so that in case any emergency comes, that has to be given to the patient. So I repeat, so a simple extraction or a scaling or any other non-surgical procedures which doesn't evoke any stress in patients on long-term therapy, the same drug steroid therapy has to be continued, no other additional medication required. If it's a stressful procedure, ask the patient to take the dose double on that particular morning. Okay, so double the dose for every stressful procedures on patient with long-term steroid therapy. Simple procedure, simple extraction, no need for additional dosage, same dosage to be continued. Okay, so that is we have to be thinking about. And I hope the things so far have been very clear. Today we have discussed about the adrenal gland, the adrenal hormones, what are the various hormones, its functions, its actions, its effects on various systems, what is the rule of twos, what are the problems associated with the adrenal glands, how were the hormones secretions regulated, and the complications arising out of it, and how to manage complications. Thank you for your patient listening. Thank you.